Good evening, students. I hope I'm audible and the audio and video are fine. Please confirm in the comments section. Please let me know if everything is fine at your end, all of you. So that we can start. So, good evening, everyone. Welcome to the MDS 360 degrees oral and maxillofacial surgery session. In today's session, we will be covering part 2 of Impactions. So, in the last part, we had covered a few topics from in Impactions. Today, we will be completing this chapter, and this is all that you will need for your exams. All right. Now, before proceeding further, we'll do a quick recap of what we did in the last session. Why? Because I would just want to quickly revise the classification of impactions, because today when we are discussing the difficulty indices or difficulty index, we will need to be thorough with our classification. So quickly, let's go through the classification in 5 minutes and then we'll proceed further for today's session. All right. So if anyone's online, anyone's joined in, you can just send in a wave or send in a hello to me. Quickly looking at classification of impactions. Especially the ones that we will need to note today to understand the difficulty indices. First one is Winter's classification. This was based on the angulation. All right. Here we had discussed, we got to know what is mesioangular, what is vertical, what is horizontal, what is distoangular, what is inverted, and things like that. All right. In horizontal, we also knew what is buccoangular and linguangular. Fine. Now the second classification that we had seen was Pellin-Gregory classification. Pellin-Gregory classification. All right. Now in this classification, there were two things that were into consideration. One was your Ramus relation, and the second thing was your occlusal relation. All right. In Ramus relation, basically we were seeing the space present between the distal surface of the second molar and the ascending border of ramus, whether that space is sufficient to accommodate the mesiodistal dimension of the impacted third molar. So according to that, this was divided into three classes: class 1, class 2 and class 3. All right. Class 1 was where there is sufficient space. Class 2 was insufficient space. Class 3 was no space or when tooth is in ramus. Second component of Pell and Gregory classification was occlusal relationship, and it comprised of position A, position B, and position C. So basically a line was drawn at the occlusal level, and the occlusal level was taken from the occlusal fossa, and it was extended backwards so that we can judge whether the highest point of the impacted tooth is present at or above the occlusal line. That was position A. And if the highest point of impacted tooth was present below the occlusal line but above the cervical line, then that was position B. And when the highest point of impacted tooth was present below the occlusal line and below the cervical line, then it was position C. Okay, so we need to remember this while we are doing our scoring. Now let's come to the another important aspect of this topic, that is radiological assessment of mandibular third molars. Now there are two aspects that come under radiological assessment. We look at the first one first. There's something known as Winter's lines or WAR lines, where WAR stands for W for white, A for amber, and R for red. So basically these lines tell us about the difficulty and depth of impaction. Let's see them one by one. First we have the white line or W. So this line is formed by joining the occlusal surface of molars and extending posteriorly over the third molar. Interpretation. This is important. It denotes the depth of impaction from occlusal plane. So I'll draw this for you. Let's say we have a scenario like this. So for white line I'm going to use a gray pen. Okay, so you draw a line at the occlusal level, and please remember you always take the occlusal level from the occlusal fossa. So this becomes your white line. All right, this becomes your white line. Fine. So this basically denotes the depth of impaction from the occlusal plane. All right, this is what this line tells us about. Now coming to A, that is your amber line. Amber is other word for the color orange. All right, so this line is formed by joining the bone overlying the mandibular third molar with interdental septum between mandibular first and second molar. Don't worry, I'll draw a diagram and you'll understand better. So the interpretation is that it denotes the depth of impaction within the bone. This triangular part is the interdental septum. Okay. This is the first molar, this is the second molar. Now let's draw the impacted third molar. Okay. So this line is drawn at the level of the interdental bone between the first and second molar and traced backwards posteriorly above the third molar. So this becomes your amber line. All right. So this denotes the depth of the impacted tooth within the bone. White line was from the occlusal plane. Amber line is the depth within the bone. Okay. Coming to the next aspect of word lines, that is R. R stands for red line. So this is formed by drawing a perpendicular line from amber line to the point of application of elevator. So basically, when you look at the radiograph, you will judge, you will try to analyze where are you going to apply your elevator, the point of application of your elevator. Now, if it is a mesioangular, vertical or a horizontal impaction, your point of application will be the mesial cemento-enamel junction, and if it's a distoangular impaction, then your point of application of elevator would be distal cemento-enamel junction. Okay, let me draw this so that you all can understand better, and in this diagram I'm going to draw all the three lines together. This is your first molar. This is your interdental septum. This is the second mandibular molar. Okay. And let's assume this to be your impacted third molar. Let's draw the white line first. I'm using a gray pen. So white line was at the level of the occlusal plane. Okay. Next, we draw the amber line at the level of interdental septum. Trace it backwards. All right. So this becomes your amber line. Okay. Now we will draw a red line. So before drawing the red line, you have to analyze your point of application of elevator. Now this is going to be the point of application of elevator. This point where I've drawn a red dot. So now you will drop a perpendicular from the amber line to your point of application of elevator. Okay, you'll drop a perpendicular line to the point of elevation of your elevator. So these three, this is how you trace war lines on a radiograph. Clinically to figure out how difficult or how deep seated your impaction is. Okay. Hard copy, okay, tooth talks, hard copies we usually don't send out. These notes are usually available on our DAMS Alpha app. So you can contact our admins and ask for the soft copies. Okay. In case you have enrolled with us, you can ask for the soft copies. You will definitely get them. Now the interpretation. So red line denotes the depth of impaction with reference to amber line within the bone. So please remember, the red line is always in reference to the amber line, because we are drawing the red line from the amber line. The red line is starting from the amber line. All right. Very important. Red line denotes difficulty, because the red line is the one which is actually telling you how deep seated the tooth is. Okay. Now a few points. So if the red line measures around 4 mm, then it's an easy impaction. Okay. If there is an increase in 1 mm of red line, it makes the impaction 3 times more difficult. So up till 4, it's an easy impaction. Okay. But the moment it increases by 1 mm, for every 1 mm increase beyond 4 mm, the impaction keeps becoming 3 times more difficult. All right. So if it is 5 mm, so the difficulty is 3 times. All right. Because with every 1 mm increase, it is going to, the depth of impaction, the impacted tooth is going to be more deep seated. All right. So let's understand with the visual. Okay. So the first line is your white line, which is from the occlusal plane. Okay. This is your white line. The second one is the amber line, which is traced from the interdental septum between the first and the second molar, and it is drawn posteriorly over the third molar. Okay. And from the amber line, you drop a perpendicular to the point of application of elevator. It is denoted by a cross in this diagram. So this is your red line and this is your amber line. Okay. Now my suggestion to all of you would be, just try to remember this visual or try to remember the diagram that I've drawn. You will not forget in your exams. It's going to be easy for you all to remember. Okay. That was all about ward lines. Now, under radiographic assessment, the next thing that we have is relationship of mandibular third molar in relation to the inferior alveolar canal. Now, we all know that an impacted third molar might be present in close proximity to the inferior alveolar canal, and we have to judge whether the nerve is actually going through the tooth or is in proximity to the tooth or is far away from the tooth. So there are certain signs which we can identify on radiographs. All right, these signs are known as Rood criteria. They are known as Rood's criteria. They were given by Rood and Shehab. Okay, in older texts they are also mentioned as Ho and Peyton's criteria. So please don't get confused. These two things can be used interchangeably, either Rood's criteria or Rood and Shehab criteria or Ho and Peyton criteria. They mean the same thing. All right. These criteria indicate the proximity between inferior alveolar canal and mandibular third molars. Let's see each of the criteria one by one. Now the first one is darkening of root. let's suppose this is the third molar. In case there is close proximity between the inferior alveolar nerve canal, then this will manifest as darkening of the apical third of the root tip. So this is a radiographic feature that you can identify on a radiograph. Okay. The apical tip or apical third will be characteristically dark in comparison to the rest of the root. So this is one of the signs which suggests that the tooth and inferior alveolar canal might be in close proximity to each other. Okay. In case you don't understand anything, you can please ask me in the comment section. We can make this session interactive, and in case you want me to repeat anything, I can repeat. Okay. You can also put in your questions in the comment section. So this is known as darkening of root. Darkening of root. The next criteria that we have is bifid root apex or apical notching. Let's see how does this look like. Okay. So this will give a picture, or this will mimic a picture that there are two apices. Whereas it actually is indicating or signifying that the nerve may be in close proximity to the impacted third molar. So you will see apical notching. Okay. Now there is the third criteria is sudden deflection of root. So this is your inferior alveolar nerve canal, and you'll see that the root tip or the root apex has suddenly deflected. This also signifies that the inferior alveolar nerve canal is in close proximity to the impacted third molar root. Okay. Now the fourth criteria is absence of cortical outline of inferior alveolar canal. First, for this, let's see what is normal. So this is your normal picture. Okay. Now what is absence of cortical outline? absence of cortical outline means that when you will trace the radio opaque superior border of the inferior alveolar nerve canal, especially near the root apex, you will see that it's either faded or it's absent or there is loss of trabeculations. So this is what is meant by absence of cortical outline of inferior alveolar nerve canal. You will not be able to trace the superior border, the radio opaque superior border of the nerve canal. Okay. There will be a break. There will be a break in the superior radio opaque border. Now the next criteria is sudden deflection of canal. Sudden deflection of canal. Let's see what is this. This means when you will trace the nerve canal, you will see a sudden dip or sudden deflection, or you will see a sudden curvature when you trace both the superior and the inferior border, radio opaque border of the nerve canal. So this means that the tooth is present in close proximity to the nerve canal. Okay. Coming to the next and the last criteria is narrowing of the canal. Now please understand, I'll zoom out a bit. So here, the width of the canal would be normal, alright, but near the root apex, the width of the canal would be reduced. So here, the differentiating point is that the lower border of the nerve canal is absolutely normal. However, the superior border, especially near the root apex, there is a dip. Hence, it causes a decrease in width of the nerve canal or narrowing of the nerve canal. This is also known as hourglass appearance. Alright, this is also known as hourglass appearance. So those were our 6 criteria of, especially radiographic criteria of identifying whether the impacted tooth is in close proximity to the nerve canal or not. Okay. Now, coming to high risk criteria. Now, there are 6 criteria which we just had a look at. Amongst these 6, there are a few criteria which tell you or point towards that there is a high possibility that the nerve is passing through the tooth substance, or it is going through the tooth, or it is traversing through the tooth material. Alright, so now what are those high risk criteria? These are very important. Please do make note of them because this is a potential question in your exams. So the first one is darkening of root. Darkening of root, absence of cortical outline of inferior alveolar canal, and sudden deflection of canal. So these three you have to remember. They are high risk criteria. What are they? They are high risk criteria. High risk criteria. So you have to remember these three high risk criteria. Presence of two high risk criteria means that the nerve is actually passing through the tooth substance, or it is perforating the root of the impacted third molar. Okay, this is what this means. So this is very important. Please make note of this. Questions have been asked from this before in the previous years, and this is also a potential question that can be asked in future exams as well. Now, with that we complete our radiological assessment. Okay, now we come to the difficulty index. Okay, we saw Winter's lines, Ward lines. Okay, after that we saw the radiographic criteria, Ruden-Shahab criteria. But to come at a uniform conclusion, so that every clinician comes at a uniform conclusion, we have certain indices in which we score our impacted teeth. Alright, those, so that whenever, even if two different clinicians are looking at the same radiograph, alright, at two different points of time, so when they score it, we get the same score. That is why these indices are there, to rule out difference of opinions in terms to the difficulty of the impacted teeth. Alright, now your difficulty indices basically include or score the impacted tooth based on their classification, based on the Winter's classification also, and based on the Pell and Gregory classification also. Alright, so now when Winters was giving his classification, he also gave his thoughts on the difficulty of the impacted tooth. So Winter's classification was nothing but it was according to the angulation. Alright, so he simply stated that if it's a mesoangular tooth, it's the simplest type of impaction, and if it's distoangular, it is the most difficult type of impaction. This is what he stated. Okay, now coming to the Pell and Gregory classification cum difficulty index. So what Pell and Gregory also stated along with his classification, that depending on the ramus relation and occlusal relation, they told us which is the easiest and which is the most difficult. So as per the ramus relation, class 1 is the easiest, class 2 is intermediate, class 3 is the most difficult. Okay, and as per the occlusal relation, position A is the easiest, position B is intermediate, and position C is most difficult. Okay, but stating about the difficulty in terms of easy, intermediate and most difficult is a very vague a way to describe the difficulty. So we had Pedersen, who came up with the scoring criteria for difficulty. He gave the scoring along with stating what is easy, intermediate and difficult. He said we will score them according to their difficulty. Alright, so what he basically did was he took the Winters classification into account and the Pell and Gregory classification. Okay, he combined these two and he allotted individual scores as per the classification. Okay, so he said for mesioangular I will give a score of 1, for horizontal I will give a score of 2, for vertical I'll give a score of 3, and distoangular being most difficult I'll give a score of 4. Okay, similarly he even allotted scores to the Pell and Gregory classification. So for Ramus relation class 1 he gave a score of 1, class 2 he gave a score of 2, and class 3 he gave a score of 3. Okay, similarly for occlusal relation he gave a score of 1 to position A, score of 2 to position B, and score of 3 to position C. Okay, now I'll give you a very simple tip how to remember. Class 1, 2, 3, so their score is also 1, 2, 3, and A, B, C are the first 3 letters of our alphabet, so 1, 2 and 3. This ways you won't forget, just remember it like that. Alright, and yes, you'll just have to remember for mesioangular, horizontal, vertical and distoangular. Okay, so now he said that the interpretation of total score is the sum of the angulation plus sum of the Ramus relation plus occlusal relation. So you have to combine or add the score allotted to the angulation plus score allotted to the Ramus relation plus score allotted to your occlusal relation. Okay, and the total score that you will get, depending on that he gave the difficulty index. So if there is a score of say 3 to 4, then it is easy or minimally difficult impaction. 5 to 7 is moderately difficult impaction and 7 to 10 is extremely difficult impaction. Now the cause of confusion here is score 7. Some authors consider 7 as moderately difficult and some authors consider as extremely difficult. For your answering or when you are asked in your exams, please always consider 7 as extremely difficult. Okay, this is the overlap score, but it is better to consider as it as extremely difficult when you have to answer your questions. So please note, Peterson has not given any index. Don't get confused. Pedersen and Peterson are two confusing names. So Peterson has not given any difficulty index. It is Pedersen who gave the difficulty index and the scoring criteria. All right. So the next assessment criteria for an impacted third molar is WOF assessment. WOF assessment. You don't need to go into the details of scoring of this. You can just remember the initials of WOF and what do they stand for. So W stands for Winters classification, H for height of the mandible, where the height of the mandible is measured from the interdental septum. That is the highest point of the interdental septum present between second and third molar to the inferior border of the mandible. Okay. A stands for angulation of second molar and not the third molar. It is this confusion has been there for quite some time, but it is always the angulation of the second molar and not the third molar. R is root shape and development. F is the follicular size and E is the exit path. Just remember this much. Don't go into the scoring. Okay. So now we come to the surgical procedure or surgical steps in uh, the extraction or removal of an impacted teeth. Okay. So we'll quickly go through the surgical steps, and I won't be able to take this in too much detail. The details of the surgical procedure I've taken in my classes, so you can go and refer our classes on our DAMS Alpha app. Okay, so we'll quickly just have a broad look on the surgical procedure. So the first thing that you place is your incision. All right. So you can either give a ward 1 incision or a modified ward incision or a ward 2 incision. Okay. The incision is usually up till the depth of the bone. You raise a mucoperiosteal flap. Okay. And most importantly, the flap is reflected by using a Mold's number 9 mucoperiosteal elevator. This is an important question point. Okay. Now, in case maximum times in an impacted tooth, you will be required to remove the bone. So in case you're required to remove the bone, you can use either a chisel or a mallet, or you can use surgical burrs. No air rotors because they cause surgical emphysema, that is entrapment of air within tissues. Alright, so you do not use air rotors for bone removal. Odontotomy. Odontotomy, again, if required, crown sectioning or root sectioning, and the goal is complete removal of tooth. This is your goal. This is the reason you do odontotomy, because you want to achieve complete removal of the tooth. Alright, and the last step is suturing. So the most important suture is the one immediately distal to second molar. Why the suture is important? Because this suture is going to prevent your pocket formation immediately distal to the second molar. Okay. The next thing is again, since we have limited time in our 1 hour sessions, so the techniques of bone removal, I'll just go through the names. The details of this I've covered in my classes. Okay. So there are various techniques for bone removal. Right. The first one is buccal bone removal technique or conventional technique. Okay, wherein the buccal bone is removed. All right. The second one is buccal guttering technique or Murray and Gilbert collar technique. So here what is done? The complete buccal bone is not removed. You create a space. You create a gutter or a space along the buccal surface of the impacted third molar. So you basically widen the space between the tooth and the bone. That is called a buccal gutter. You create a corridor in the buccal bone so that you can facilitate your impacted tooth removal. The third one is lingual split technique or Sir William Calcifry technique. And the fourth one is modified lingual split technique or Lewis technique. So these are the techniques of bone removal. Alright. So this is the last part of our session. If there are any doubts, you can ask me in the comment section below before we wind up this session. In case you're finding our sessions helpful, please like them, share them with your friends, subscribe to our YouTube channel. We will be here to help you with your preparation. Okay, and this is your schedule, upcoming schedule for this week. You can take a note of it and join our sessions every day live on the DAMS MDS Quest YouTube channel 8 p.m. onwards. In case you have any doubts after the session, you can leave your doubts in the comments section. We will try and get back to you and answer your doubts. Thank you for joining in, students. Happy studying. Good night.